Good morning, everybody. All right. It's a little sleepier than 2 days ago. That hello, but you know what? That tells me you're having a good time. So let's try it again. Good morning, everybody. Yay! I'm very excited to be back on our final day. I'm sad it's our final day, as I'm sure all of you are, but I'm so excited to be back again with you. And I think yesterday was a fantastic day full of fantastic sessions, happy hours, talent shows, sing-alongs. Let's give a shout out to those who participated in the talent show. Let's give them a round of applause. Personally, that's one of my absolute favorite parts of every conference, seeing the amazing talent and seeing the amazing courage to get up on stage. Just absolutely fantastic. So I hope those of you who didn't participate and were thinking about participating are already planning your next time for 2 years, what you're going to do on stage. So we've got a great day ahead of us. Again, our final day. A couple of things I want to highlight for everyone are tonight is the dinner. Very exciting dinner dance. How many people have been to one of the conference dinner dances before? Raise your hand. All right, let's get a round of applause for how many people that's your favorite part of the conference. Yes. So that'll be very exciting. And who knows what happens at that dinner dance besides a lot of dinner and dancing? Gretchen, tell us what happens. Yay! We'll announce where we're going to be in 2 years. So super exciting. The last thing I want to mention is this afternoon, we're doing a session about events. So Irene Smith, who's fairly new to the foundation, is going to be leading that. And why I'm super excited about it is I've been doing events for the foundation. This is going to be our 19th event. And I've loved every second of it and super, super excited. Eileen is amazing. She comes with lots of great ideas. So if you're thinking about doing something at all or thinking about how do I get involved, how do I get more involved in my local community as it relates to events, come pop by. I'll be there as well. And it's really, really fun and exciting and another way to get involved. So with that, we're going to get going on our amazing panel this morning. You are here to learn about and hear about understanding and managing pain in OI. This is a really critical priority for the foundation. We know what a major issue it is. We've heard the past few days, a lot of the team and the physicians say, we do these surveys and we've done the survey and we hear you loud and clear. The OI Foundation partnered with the OI Federation of Europe to establish the OI Pain Project. Dr. Weiss is going to talk a little bit more about that. Conducting a pain survey, we received 1,100 responses in less than 6 weeks. So you've heard a lot about how important that is. And with that, we're going to spend some time really digging into it and talking more about why that's important and how the teams are here to meet the needs of the population. So before we do that, though, we have a very special message from someone who we all adore in this OI community, adore more than I can even articulate. Dr. Francis Glorio, who can't be with us today. Yep, let's give him a round of applause. The man needs no words. If you have not been in his presence or worked with him or spoken with him, he has been an absolute trailblazer with the OI community. He's done more things than I can even express and touched so many lives, had a beyond significant impact on people with OI for decades now. So he can't be with us, unfortunately. It's not the same without him. So he wanted to send a message to his OI family.
Go. Hello, everybody from the OIF and the COIS community. This is Francis Glorieux in Montreal, and I should be in Omaha with you. Unfortunately, for a reason that I cannot control, my aging system makes it that I have to stay in hospital at the moment for various reasons, and I don't see the end of it for the moment. But my heart is with you in a meeting that I was looking forward to attend. You know, that being so long in the hospital is teaching me another lesson that most of you have, and which is to be out of the world, active world, and be forced to do things that you don't like to do. And for that reason, I understood even better every single one of you. So have a good time in Omaha, learn a lot of things, talk to each other, and think of your old friend who is in Montreal, Canada, where the weather is nice, by the way, and he would love to be with you and give a big hug to every single one of you with my best wishes. Have a good meeting. Go.
We love you, Dr. Glorio. So anyone feel free to drop him, a text, an email, a note, just letting him know, we miss him and we're thinking of him. So without further ado, I'm going to turn it over to our illustrious panel. And I'm going to set them up. They're going to give a little bit of an introduction about who each individual on the panel, a little bit about their background, and then we're going to give each one of them, very similar to yesterday, a chunk of time to talk through various topics, and then we will moderate a Q&A. So Chris Joseph, Ricky Carroll, Mercedes Rodriguez-Celine, and Andrew Weiss, who actually, Andrew will be on video with us because he, like many people, his flight got canceled. So we're lucky enough to still have him be joining. And with that, I'm going to turn it over to you. Here you go.
Hi, good morning to everyone. I am Mercedes Rodriguez-Celine. It's a pleasure to be with you today. I am a pediatrician doing genetics training. I've been working with patients with OI since 2007, doing clinical practice and also clinical research. So it's a pleasure for me to be here today. So I want to thank the OIF for inviting me and for putting together this amazing conference. And thank you all for being here. It's a pleasure for me to share with you the results of the multi-center study of pain that we did because all of you answered our questions and it's part of the BBDC study. And we know that these results are important. We published this information last year, but it's good to have the opportunity of sharing with you the of the results. So the idea is first of all to share why we wanted to do this study, then some of the results of the multi-center study, and then I want to share with you what did we learn after doing this study. So we knew that OI, and we know that OI is associated with significant morbidity, and we know that the ultimate goal of treating OI is to improve mobility, participation, quality of life. But we know that there are many factors that can interfere with this. So in the last few years at Trainers, we were able to collaborate with different studies that try to understand how fractures and welding surgery affect all these outcomes. If there was an improvement with welding, also we did the multi-center study of mobility and trying to understand how mobility is affected by disease severity. We also did a study about how if bisphosphonates were useful or not to alleviate pain. So with all these studies, we saw that pain emerged like a common field in all these studies and reported by the individuals participating from these studies and from the literature. So why do individuals with OI have pain? And we know that there are many causes for bone pain in musculoskeletal disorders, and we all know about the orthopedic causes for pain, like fractures, deformities, surgical hardware. So we know that that's present in OI, but we also know that there are functional causes for pain. And you will see that I underline all the ones that I feel that I related with pain in OI. So you can see that these are a few. So abnormal gait, muscle weakness, also poor positioning using wheelchair, joint stability, leg discrepancy, but also neurologic causes for pain, like nerve compression or post-surgical pain, inflammatory. We are learning about inflammatory pain in OI, and also metabolic causes like high bone turnover can be associated with pain in OI. So with all this, you can see that pain is multifactorial in OI, so there can be many causes in the same person, and there can be different causes across different individuals with OI. And we can understand that looking to all these causes, why pain can be complex and difficult to treat, and we need to understand better in order to be able to treat it better. So, but we know that individuals with OI not only have pain after a fracture or acute pain. We know that individuals with OI have chronic pain. And I brought here 2 cycles, and I know you're familiar, especially with the first one, where it has been described, and we know that fractures can predispose, of course, to have pain and to mobility, and this brings the conditioning, and this will bring ultimately more fractures. So this is a vicious cycle. But it has also been described a different cycle where pain and progressive deconditioning is associated with decreased participation and with mood disorders such as depression and other problems. So we know that these cycles are hard, are difficult to break, but understanding better, we feel that we can do a better job trying to help individuals with OI get out of these cycles. So what did we know from the literature before doing our study? And the first study that focused on pain was done by Zach in 2005, and he did like a survey and a study in 35 children with OI, and he found that pain was common. So that was the first finding, and also that it was interfering with these children's daily living activities. In 2018, Suicide did with him in 2017 did an integrated review where he analyzed 19 studies that at some point spoke about pain, and what she found is that research has focused very, very little on pain experience and pain characteristics, and they were focusing on other topics. So I say in 2018, look into the insight from the OI community and patients' perspective. So this was very important, and we heard and we learned that pain was referred as an ever-present burden in their life, and also that it was not always addressed and fully understood. And the last 2 studies that we were able to perform at Trainers in Chicago in the mobility study, we were surprised when we saw that 40% of the individuals with OI referred pain as an limitation to walking. Of course, we were interested in knowing all about mobility, and we asked what are the limitations, and we were surprised that one of the largest limitations was the pain. That is something that should be treated. during the systematic review that we did about bisphosphonates and pain, again, we saw that pain was understudied. It was very difficult to find studies where the pain was considered like a primary outcome in most of the study. Only intensity was assessed, not a multidimensional evaluation of pain. And we saw that this is a multidimensional experience, and we need to ask about how this is impacting individuals' life. So the summary of the background that we had before starting our study was that only a few small studies has focused on pain in one, and pain seems to limited activities and affects individuals chronically. And from patients' perspective, pain is not always addressed and fully understood. So the hypothesis that drove our study was that pain affects all eye types, because this is what we were seeing, that the people were referring to us, and that interferes with activities, and that it was not only related to fractures, but related to different variables and situations. And we also assumed that it was not always effectively treated. So we wanted to know all about that. So the idea of our study was to describe the frequency, location, treatment use, pain intensity, pain interference, and look for associations and predictors for chronic pain. You will see in the results that we were kind of limited with the information that we could have from adults, because we use proxy for many of these variables to evaluate many of these variables that is only available for pediatric population. So you will see that part of the adult information came later from different surveys and other studies. But we were able to use the data from the BBDC, and we were lucky enough to have information from 11 different recruiting sites with more than 900 participants enrolled, and of course with all your help, the retention was very good along the years. So we were interested in knowing a lot about the variables that could be associated with, that were relevant to pain. So you will see that we ask about presence, duration, location, and treatments, but also what are the clinical variables that are associated with pain, and also functional outcomes. As you know, there are many tests and different tools used to measure function in individuals with OI protocol. So we try to see how this play a role with pain. So overall, we were able to have information about chronic pain in 861 individuals with OI, at least from one visit, and you will see that there are aware individuals that they have information that it was done
for more than one cycle, for more than 1 year, and that was very helpful in order to see predictors and see fluctuations. So as in most of these studies, around half of the individuals had OI reported having OI type 1, and the rest of the individuals had the different OI types. So the first and important finding was that 42% of the participants reported having chronic pain. So almost half of the individuals reported having chronic pain, and this was a big number. And if we look into the adult population, we found that 70% of the adults reported having chronic pain. So that's get even worse. When we analyzed by OI type, we found that this was, as we assumed at the beginning, that this was similar across the different OI types, and this was not limited with the severe forms of the disease. You can see no significant difference. Then we wanted to see where was the pain located, and so most of the people have more than one pain location, but back pain was the more frequent location reported in all OI types, followed by multiple bones and joints. And this is something also important because we haven't explored a lot about joint pain in OI. And we found that individuals with OI have pain in multiple sites, and the number of sites affected by pain was also similar across the different OI types. So no matter what type of OI you have, you may have pain in different sites. So then we wanted to know a little bit about functional outcomes. I only brought here some of them because we really did a lot of different testings and we used different tools. But for all of them, it was true that the group with chronic pain were performing worse in all functional outcomes. So we can see how pain affects function. And not only that, but individuals with chronic pain miss more days from school or work than individuals without chronic pain. So that also shows the importance of addressing this problem, this concern. So regarding participation, as I said, we were only able to evaluate this in children, but we saw that pain limit all type of participation, things that we want the children being part of, and also, so all types of activities were affected. Social participation was the one thankfully less affected, but you can see that all of the activities evaluated were affected. And also we found, as we were expecting, because this was similar that in our previous study, that pain was a limitation for walking across all OI types. And you can see that this was reported in between 35 and 45% of the individuals. So this is very high, and we hopefully we will be able to do something about it, and that people can walk and move around. So regarding pain interference, we were able to address this in adults and in children. And you can see, if you see this graph, so yellow is moderate interference, blue is severe interference, and green is extreme interference. And you can see that with age, the intensity of pain interference increase, and that we found that around 70% of the adults refer having pain interference with activities, and that pain interference significantly increases with age when we compare children to adolescents and adolescents to adults, and especially adults older than 40-year-old. So then we wanted to know what people, what individuals with OI were using for pain relief. So we divided the therapies into different classifications, and we name classical therapies, the ones that we ask. Are you using NSAIDs? Are you using bisphosphonates, massage therapy, narcotics, TENS? And as you can see, the treatment more commonly used was NSAIDs, ibuprofen mostly, followed by bisphosphonates. And you can see that the reported effectiveness was variable, but it was reported to be effective, NSAIDs and bisphosphonates around 75 and 83% of the cases. Then we also ask, and I think this is an important result of the study, what other treatments are you using? And this is good, and this is valuable information for us, because the people told us, okay, I'm using this and that and that and that. So it was important to see how people were combining their therapies and what was effective. And you can see that the reported effectiveness here was like incredible. So of course we have little evidence for many of these treatments, scientific evidence about how they work, but at least this information is valuable for us. And as you see, people were also using, well, of course, Tylenol, but heat bath, cold bath, hydrotherapy, cannabis, stretching, and other treatments like muscle relaxants, or acupuncture, or relaxation, or distraction. So all these things that people reported being effective for them. So we also wanted to see how people were combining their treatments, because as I said, most of the individuals were using more than one treatment, and you can see that we found like a median number of treatment was 2, but we have individuals that use like up to 7 different treatments for pain relief. And that's a big number. So what we found is that most of the individuals found effective to combine pharmacological and non-pharmacological options. So the combination more frequently used was NSAIDs, plus physical therapy. So this is what people were reporting, and this was followed by NSAIDs, bisphosphonates, and physical therapy, like the second option, more the combination most frequently used. But we know that there are certain individuals that require up to 7 different treatment options to find pain relief. And we know that in some cases there is also residual pain, even they are trying to do everything to control this problem. Something that it was also important for this from this study is that we asked the patient, what are you expecting for treatments? And we found that adolescents and parents, their highest expectation for treatment was to have pain relief. So that's why it's so important we are doing these meetings and we are talking about this. And this was more important than any other aspect of their treatment. So we also wanted to know what were the variables associated with pain, with chronic pain, to understand better. And we saw, of course, that age was a significant variable, and that pops like the strongest association with chronic pain. But we also saw that being female, having scoliosis, using wheelchair, having a higher fracture rate per year, or having higher BMI was associated with having chronic pain. We also found, we were interested in knowing about predictors of chronic pain. And for this, we use the data that we have from the longitudinal data from all these patients that come every year. And we look into predictive factors. So this we think is important because if we see these factors, we can predict that that individual will have pain now or in the future. So we need to do something. And we also found a protective factor. So regarding the predictive factors, we saw that the use of wheelchair, older age, a higher fracture rate, was true, like a predictive factor in all OI types. And for the milder forms of the disease, also being female and having a high weight C-score was associated like a predictive factor for having chronic pain. And we found that for OI type 3, for the more severe forms of the disease, being under active bisphosphonate treatment acted like a protective factor for having chronic pain, and that was an interesting finding for us. So some conclusions of this study is that chronic pain is present in more than 40% of the participants. Pain affects similarly all OI types. The frequency of chronic pain and the interference increases with age. We know that participants with chronic pain miss more days from school or work and perform worse in all mobility outcomes evaluated. Pain was more frequent in females, Medicaid insurance, participants with wheelchair and assisted devices. Pain is associated with scoliosis, BMI, fracture rate, and rodding surgery. We also know that age, wheelchair, and fractures were predictor factors, and that using bisphosphonate was associated with lower scores in the pain interference scale, and also was found to be a protective factor for chronic pain in our study. So last thing is what did we learn with this study? First of all, that pain needs to be evaluated in every visit. You can see with the frequency and the big problem that this is for our community, we need to be asking about pain. We need to be assessing pain. And I would say not only asking about intensity, but if we can use a multidimensional tool that is the best scenario, because we will understand better how this is impacting the different aspects of the individual's life. Also, pain is personal and multidimensional, so we need to approach an individual with pain with an open mindset, trying to understand their experience. Even though sometimes it's not easy to understand pain, we know that we need to treat it. We need to try to address it. I show those cycles of chronic pain. We need to try to break those cycles. And we know that there is magnification of pain over time. And the chronification of pain is, once this happens, is more difficult to treat. So we need to act early as possible, trying to understand and to treat better. And of course, for this, we will need multidisciplinary team. And we need to take into account individuals' perspective, what is helping, what is not, what helps in the past, or what do you want, you don't want to do again because you don't like that approach. So that is crucial. And of course, adults require special attention. So we learned from you and from all these answers that we need to work with a multidisciplinary team. And these are some of the options that were more frequently reported, and that we know for many of them we have evidence. But we know that some patients will require surgery, and after that they will require muscle relaxants and physical therapy. Some of them will require psychotherapy in order to break this cycle. Some of them will require assisted devices in order to be able to move and to be more comfortable and to put less stress on their bodies. So we need to think of all that, but we also need to be open to new treatments and to different options, and to hear what people are using is helping, and also to look for more scientific evidence that support different approaches to treating chronic pain. And we learn from these answers that people with OI, they are already using, like there is like a newer approach to pain and to treating pain, and the use of analgesia recommended by the WHO, where in what we are trying is to, of course, use less opioids and to put more steps in the ladder, that it was typically a 3-step ladder before, and also to add different adjuvant treatments and integrative medicine therapy. That is all what individuals has been reporting. I do acupuncture, I do yoga, I do this or that. So all that is integrative medicine therapies, and we need to see if they are helping. And of course, if we can help with research, that will be great. So thank you for all of you for participating from these studies. We cannot do anything and learn anything without you. Of course, thanks to the BBDC members that work hard to have all this data across the country and outside too. And thanks for the OIF and the rest of the institution for supporting this research study.
All right, we're going to go to Andrew Weiss, who's joining us virtually. Gotta love the hybrid environment.
Right. Just to confirm, are folks able to hear me okay there in Omaha?
Yes, we are. We can't see you, but we can hear you.
I'll just be an enigmatic voice and some slides here for today, if that's okay with folks. But thank you so much for the opportunity here. Again, my name is Andy Weiss. I am a clinical psychologist and faculty member over at Baylor College of Medicine. And as much as I really wanted to be in Omaha presenting in person, being able to see all of you, the airlines and this Microsoft update kind of derailed plans for myself and many other people. So I appreciate the flexibility, the understanding here, and I'm excited that I can still connect with the folks here in Omaha and kind of talk about some of the work our team has been doing, highlighting the Pain and OI project, and then also some of the other research initiatives that our team at BCM has been undertaking. I am a little bit newer to the OI field, so I've been very appreciative of how warm and how welcoming this group is and how interested they are in involving as many members as possible from different research communities. So I just want to start with a big thank you to both the OIF and the members of the community for including me over the last number of years to help address some of these questions. So quickly, just some financial disclosures that funding sources, no conflicts of interest for me to report. But why might a clinical psychologist care about pain? Well, we know pain is a subjective sensory experience. We often see pain following tissue damage, although there are other things that can contribute to pain that are not reflected by tissue damage. We often think of pain as chronic or acute, the former referring to this long-lasting pain that we see after injury and subsequent healing, while acute pain refers to time-limited physical sensations, usually immediately after injury or some other sort of experience. This is not specific to OI, but in general, looking in the pain health literature, we know that elevated levels of pain, high frequency of pain, high intensity of pain, we know that that can contribute to feelings of anxiety. So this future-oriented worry or fear specific to the sensation of pain. We know that pain is associated with depression, so down mood, feeling blue, feeling hopeless or helpless in certain instances. We know that pain contributes to unhelpful avoidant behaviors, so individuals withdrawing from day-to-day activities that they may otherwise want to be doing. We can see this avoidance because of fear of pain or because the actual experience of pain in that moment. There is an association between pain and alcohol and or substance use. That's not to suggest every person who's experiencing pain will rely on these things or go to them, but just to note that there is an increased likelihood that we may see problematic or impairing alcohol or substance use when pain is present. Pain is associated with different educational outcomes, so missed days in schools, or lower educational attainment. And then similarly, we will see that in work settings as well, where there are missed days of work, perhaps more difficulty obtaining a job, and perhaps more difficulty retaining a job because of pain. Most importantly, for us today is we know that pain is extremely common in the context of OI. But again, still, how might a psychologist fit into this picture? Well, within the profession of psychology, there is a subspecialty referred to as health psychology. So this is looking at both psychological and behavioral processes and how they impact one's health, how they interact with the disease or illness, and how this might impact healthcare and healthcare settings. So we're really looking at it from a biopsychosocial lens where we're looking at biological predispositions, we're looking at environmental factors that may contribute to pain, and then also psychological factors. So how might one interpret the experience of pain? Might they worry more relative to someone else about the pain that they experience, and how does that impact their quality of life, their ability to engage with their loved ones, do the things that are important to them? So we know that pain can contribute to psychosocial functioning. We know oftentimes it results in impairment in functioning, but we also have a pretty robust health literature, health psychology literature showing that different psychological interventions can actually be effective for helping in these areas and help overcome some of these limitations. There are large research organizations and treatment groups in other health populations. So this is not an exhaustive list, but just to highlight some of the big organizations out there looking at health psychology. So I think the largest one that receives the most attention, and I don't know this for a fact, but I suspect they probably have the most research funding, is oncopsychology or psycho-oncology, depending on the verbiage you prefer. But this discipline is looking at the interplay between cancer diagnoses and how that affects family members, individuals undergoing cancer treatment, and providing psychotherapeutic interventions to help them improve their quality of life and do the things that are important to them. We have psychologists in bariatric settings, so promoting weight loss interventions through behavioral change, or conducting psychiatric evaluations before different bariatric surgeries, whether it be gastric bypass or lap band surgeries, to determine psychological fitness for these very invasive surgeries. We have psychologists in rehabilitation settings. We have them in consultation liaison roles, floating throughout hospitals, consulting with patients as they present. Behavioral medicine, we have psychologists there doing things such as smoking cessation, behavior changes around that, and weight loss and other things. There are special health psychologists who specialize in pain, but as many of us here know, there are very few of them that are doing this within the context of OI. So there's very little research out there on pain and its associated concerns among those with OI relative to our other health populations. And there's even less specific to psychotherapeutic interventions for pain and OI. I want to kind of provide a quick example of just how salient this is. So this slide here, I know it's blank, but I promise you that I'll present some things in a second. But what I did the other day is I just did a PubMed and a Google Scholar search where I typed in different psychotherapeutic interventions like cognitive behavioral therapy. Then I typed in a health population like cancer or diabetes. And then I typed in the word pain and I hit enter. And what I saw were just countless hits for these psychotherapeutic interventions for other health populations. So things like this came up and were very easy for me to find. Psychological and behavioral approaches to cancer and pain management, effectiveness of acceptance and commitment therapy on depression and sleep quality in painful diabetic neuropathy, internet-delivered CBT pain management program for spinal cord injury pain, cognitive behavioral therapy for bariatric surgery patients, preliminary evidence for feasibility, acceptability, and effectiveness, cognitive behavioral smoking abstinence intervention for adults with chronic pain, or an RCT pilot trial. Promoting psychological flexibility in parents and adolescents with chronic pain, pilot study of an 8-week group intervention. This took me just a matter of minutes to curate all of these manuscripts, the abstracts and the titles here. And what took the longest was actually cutting and snipping and then fitting them to my PowerPoint slide. I tried doing the exact same thing for OI, looking up OI or osteogenesis imperfecta, or even use the term brittle bone, typing in psychological interventions and then pain, and the hits were far fewer, right? So reiterating this point that relative to other health specialties or other health populations, we don't quite have as robust of a literature yet. So what are we doing about this? Our team has been involved with a couple different initiatives. The Pain and OI project is one of the more exciting and newer initiatives we've had the privilege to help out with. But this joint effort by both the OIF and OIFE resulted in a massive data set that they have, we're very grateful they allowed us to borrow the data set and start analyzing. And we haven't published the data yet, but we hope to submit soon. And then if any of my co-authors are there in the audience, I promise you I'll have a draft of the manuscript to you soon. It's on my desktop right now, so that is coming, and I apologize for the delay there. But this survey was developed, as I said, as a joint effort between the two organizations, 27 different contributors spanning 11 different countries. As you can see, there are many different medical and research specialists involved. But most importantly, individuals from the OI community helped contribute to this survey because they had a unique lens or a unique perspective on pain and some different aspects that they wanted to make sure were assessed, which I think is a very important way to do research, is involving the population of interest from the bottom up. So this was an iterative process where we had multiple Zoom meetings where we discussed the constructs we need to assess. We talked about the best way to ask these items. And after multiple rounds of revisions, this survey was distributed globally via SurveyMonkey, which is just an online survey platform. And I suspect many of you there today participated in the survey. And if you did, I would like to thank you for your data and for your interest in participating here. So again, these data have not been published yet, but just want to provide some highlights what we're seeing so far. So as was mentioned earlier, there were, I think, over 1,100 individuals who at least opened the survey. Of those, one of my former trainees, Dr. Miranda Hyam, she helped clean the data and help us analyze it. We identified 821 usable participant data sets. So for one reason or another, we had to remove some folks from our data set, whether it's because of atypical response patterns, large swaths of missing data, so we couldn't analyze the variables of interest. But nonetheless, a very robust sample of over 800 individuals, which is very impressive. With our demographic data here, some things that stand out and I think are calls to action and things we need to consider in future OI research is who is completing or who are completing these surveys. So over 70, just about 74% of this sample identifies as female. I think also of note, almost 88% of the sample identifies as white or of European descent. So in health literature, there's a lot of emphasis put on this idea of intersectionality. So looking at health conditions and how does that interact with somebody's minority status, sex, gender, sexual orientation, things to that effect. We know that individuals of minority status who have OI or have chronic health conditions, they may experience the world differently relative to those of majority status. So while this is a very robust study sample, I do think we have room to improve and come up with ideas or ways to access subsects of our population that are less represented in these data here. I'm not sure how well you can see this. This is a lot of information, and this table is rather large, but again, it's hitting on this idea of representation. So of the 821 participants we analyze in these data, 60% are from the United States. The other large groups are from English-speaking countries, whether it be Canada, Australia, United Kingdom, and Ireland. So again, a call to action here that if we really want to help all of those individuals who have OI, we need to get creative and figure out how can we better access folks who are not represented here. So from other countries speaking other languages. When we were analyzing these data, we had a lot of great conversations and going back and forth about how should we look at pain. One of the easiest ways we could do it is looking at pain and different outcomes based on self-reported OI type, but that's been done quite a bit. And there's some concerns with that approach. Folks may not know what OI type they have. Their OI type diagnosis may change across time based on presentation, based on different providers. And when we used that in our initial set of analyses, we had to remove a lot of participants, more than we did the data I'm presenting here, just because there was a lot more missing data. So I think we had to exclude about a third of study participants, which we wanted to represent as many folks as we can. So what we landed on is we wanted to use self-reported pain frequency and self-reported OI severity. So how often is an individual experiencing pain? And then from their perspective, regardless of if they have type 1 versus type 3 versus type 4 or 5, we want to know from their perspective, how severe do they see their presentation? So we use these two variables as predictors, and then we looked at different outcomes that were collected in the survey. And this is a simplified version. I wanted to get rid of the statistics because I think it can kind of muddy the picture here. But what we found here was that pain frequency was an incredibly important variable. We saw that those who report pain every single day, they reported lower physical health relative to folks who have less frequent pain. Our folks who report pain every single day reported lower quality of life relative to folks who report less frequent pain. And this is consistent with what we've seen in older OI literature. This next finding we have, I think, is very important and interesting, but those who have pain every single day reported that their healthcare providers or their medical providers don't quite understand their presentation. And I think this conceptually makes sense. Pain is very salient. It's a motivating sensation. It's designed to push you into doing things to get rid of pain. And if pain is not being controlled, of course, we're going to say our providers they don't get it. They can't treat this very salient symptom that I'm struggling with or that I'm experiencing. Those who reported pain every single day, they also, there's statistically significant main effect on sleep. So they reported less sleep and more impairment with sleep. And then also those folks who experience it every single day reported higher levels of anxiety and depression, which mirrors what we see in other health populations, other chronic disease populations. Interestingly, we did not see these effects for perceived severity. So when people said that their OI was severe versus not severe, those differences weren't emerging. It was really how frequently do they experience pain, regardless of how severe they view their OI diagnosis. So I think this reiterates the point that pain is very important. And Mercedes mentioned this in her presentation, that we really need to be assessing and making sure that we are treating to the greatest extent possible, whether it's through physical therapy, pharmacological interventions, or psychotherapeutic interventions that I hope will start to become disseminated with an OI population soon here. So we can certainly quantify pain, right? We can run fancy statistical models and assess how much pain contributes to how much depression in a large sample. But one of the other initiatives our team has taken in recent years is going to individuals of the OI community, interviewing them, and hearing what are the things that stand out to them. So one of our recent studies that we're just finishing up our last couple manuscripts here, we interviewed adults and children with OI, caregivers of individuals with OI, and then healthcare providers who work with individuals with OI. These interviews covered characterization of OI, mental health concerns or mental health symptoms that might be noted in the sample, pain challenges, and then priorities for future interventions and resources. One of our manuscripts in this area, Mr. Connor Rourke, he was a former trainee of ours. He's now a med student in New York. He published a manuscript on psychosocial burden and positive outcomes associated with pain and OI. One of the salient themes that emerged following our thematic analysis was that there were difficult experiences when recalling prior injury and pain. So a third of the adults we interviewed reported things like this. So this is a quote from one of our participants where they said, "I'll just be sitting on the couch and I'll get like PTSD from a fall, or I'll start having psychological pains in my leg," right? This recollection, this recall of prior difficult experiences related to pain. Connor also noted that, or found that adults can manage pain through various means, including cognitive reframing, so changing the way in which they interpret their experience of pain. Spiritual and religious coping was noted by almost half of the study sample. And then exercise was identified as a very important activity to help modulate pain. So this quote here, I mean, I would say like, I'm used to it at this point. So I was like, I just think about the positives, like, and just try to focus on the good, right? So the individual is not denying the presence of pain, but they're demonstrating this psychological flexibility and this ability to reframe what it is they're focusing on in their life. One of our other pieces by a former trainee, Miss Whitney Shepard, who just started her PhD program at the University of Kansas. She published a manuscript from these data looking at adults and their experiences with pain and their ability to cope. All of our adults in those interviews reported pain, and almost all of them reported some level of impairment associated with that pain. So this quote here from a 67-year-old female who we interviewed, she stated, "It's a long recuperation time with a lot of pain, losing physical height from surgeries, and it's a big chunk of my life sort of put on pause." Our participants also noted that there are negative cognitive and emotional outcomes that we can see because of pain. Very often, the bone pain gets to scare me. You know, I'm in so much pain that if I keep using my arm, I'm scared. Well, those findings and those anecdotes are a bit grim. One of our other former trainees, Ms. Hannah Cho, she took a different perspective. She wanted to look at resilience. So we know pain was present. We heard it through all these interviews, but how do people overcome? How do they adapt? How do they demonstrate an ability to do what is important in the context of pain? So many of our folks reported pain. However, they also noted an ability to overcome. And I absolutely love this quote from one of our participants because I really think it highlights the idea of resilience. "I took a coding test for one of my classes, typing with my feet, which I think is so cool because it highlights the fact that this person does not want their pain to stop them from doing what is important in their life." Our adults reported principles of acceptance surrounding pain, so acknowledging its presence, but not letting it dictate how they engage with the world. So this quote here, "I am able to do the regular daily things that I do, but sometimes I'm in a lot of pain, and sometimes I'm not able to do as much." Or, "I had to kind of give up that perfectionistic streak that I've had, and I had to really relax. I had to let go because there was so much that I couldn't control." We have a couple other pieces. These are earlier on. I'll touch on these quickly, but Miss Julia Morales, one of our medical students, she's analyzing our interviews with our children with OI and looking at school experiences among those kiddos and understanding how might pain impact school, what sort of services are available in school settings. Another medical student, Miss Selena Go, she's looking at facilitators and barriers to care among those with OI. So she's analyzing our interviews with healthcare providers and caregivers. And one thing that's coming out in those data are that our participants really like the idea of integrative care. So having easy referrals from our surgeons or from our physicians to physical therapy, to psychology, to psychiatry, occupational therapy, and so on. It came up with both our providers and caregivers noting how important that is. Earlier in development here, Mr. Justin Kwan, one of our former med students, he's looking at perspectives on pediatric OI and mental health challenges through our child and caregiver and provider data. And then Ms. Gianna Colombo, who I believe is there representing our Baylor team, she also has a piece in development looking at caregivers and families and the impact pain has on the entire family unit. So what I want to end on, we have many other studies that are ongoing and things that we want to do in the future, but I want to conclude by highlighting the importance of what we call community participatory research. So oftentimes research is designed, implemented, and disseminated by researchers, clinicians, subject matter experts. And that paradigm or that modality of doing research is really helpful and has caused many advances in many healthcare disciplines, many fields of science, but sometimes it misses important details. So community participatory research is this idea of going to the community of interest and involving them at every phase of the research, as early as identifying what we should assess, how should we assess it, who should we assess it with, and then how do we disseminate these findings to improve the world. So it's this idea of more of a bottom-up approach rather than a top-down approach, which we often see in different sciences and healthcare disciplines. Descartes has this idea, this early idea of subjectivism, right? We only see the world through our two eyes, and my reality is not the same as yours. And I think we need to have a seat for everybody at the table as we're trying to assess and we're trying to address pain. So I really want to just kind of conclude by emphasizing we need not just researchers and clinicians, but the very active members of the OI community to continue helping us and encouraging us of different things that need to be addressed as it relates to pain. So I want to acknowledge a number of folks from our Baylor College of Medicine team, folks from both the OIF and OIFE, members of the BBDC with whom we collaborate on many of these projects, and most importantly, every single person from the OI community who allows us to do this amazing work. I will wrap up with a shameless plug for one of our ongoing research studies, if anyone feels so inclined to scan the QR code. Also, one of our coordinators mentioned is Gianna Colombo. She should be there. And if anyone is interested in participating in one of our ongoing surveys, please connect with her and she can help get you all set up with the survey. I can also email the link to folks who might be interested. So thank you very much.
Thank you so much, Dr. Weiss. We really appreciate you joining us virtually. That was fantastic. Chris, over to you.
Thank you. I'm Christopher Joseph. I'm the Director of Physical Therapy for the Kennedy Krieger Institute. I'm also the primary PT in the OI clinic, and I am the primary PT in the chronic pain clinic. So I treat chronic pain throughout the lifespan of individuals with not only OI, but cerebral palsy and other conditions as well. I'm going to talk to you today a little bit about treatment from a physical therapy perspective, but I do touch on things like we partner with everybody. It's a multidisciplinary approach at Kennedy Krieger in our connective tissue clinic. Oh, the clicker's not working. There we go. Okay. So I'm talking about pain and fatigue and osteogenesis imperfecta from the connective tissue clinic perspective. I have I talk a little bit about research and evidence in the beginning, and it's a lot of overlap, which has already been said. I have nothing to disclose. I'm not a researcher. I'm a clinical clinician. I'm talking to you a little bit about understanding the perspectives of pain and the clinical presentation of pain in OI, We're going to do some overview of, again, some of the research, but it's repetitive, what you've already heard. And then I'm going to talk to you about some treatment, because that's, I think, what you're here for, is to hear about treatment too. So we know that there's common things that happen that cause pain and fatigue in OI, recent fractures, deformity, weakness, impaired muscle strength, impaired muscle signaling, low muscle tone, joint laxity, instability, weakness. Some of the research you've already heard, but I have some other stuff in here, like patients with, people with OI have a lower than normal force production. This is from research for OI type 1 mice. You have impaired muscle endurance because of your impairment to your type 1 muscle fibers, higher weakness in response to injury. You guys, when a person with OI is injured, their muscle becomes instantly weak sometimes and they can't move. It's actually sometimes perceived as a fracture. More muscle stiffness is reported, as well as more pain perceived as a fracture. More pain is also sometimes perceived as a fracture. And then you have abnormal signaling from your muscles, from the breakdown of your bones from the osteoclasts. Research and clinical experience shows that, there's poor biomechanics, bone deformity, as well as contracture can impair biomechanics of muscles, which can lead to pain. There's impaired, again, we talked about not only impaired signaling from the osteoclasts, but also from the muscles, the tendons and joints. And then this all presents with pain for people with OI. So muscle injury, I talked about this a little bit before, but muscle injury can be perceived as fracture at times. It can also be a debilitating as a fracture. So an injury to a muscle, the collagen in your muscle and the fibers in your muscle are impaired. So if you injure a muscle, it can lead to instant weakness, but also pain and be debilitating. It also impacts your balance and protection for mobility. So, you really want to avoid that pain and cycle. So if you reach a period of pain and you get into a cycle of rest, immobilization can lead to fracture and more pain. So we really it's important to stay active when we have periods of pain. Oop, it went too far. Okay. Some of the things we learned in the clinic about adults with OI, osteoarthritis starts early. It impacts the mobility of the joints and the joint signaling. We also see more pain reported from the clinic for the more severe OI, but we also see some more pain reported for walking versus non-walking patients. So patients who are walking with more severe OI choose to go to a wheelchair sooner because of that pain perceived on mobility, but staying active is really important. So hypermobility can also lead, and poor alignment, we see this with adults with OI as well, can lead to extra joint stress. It can lead to over muscle stress, which can lead to pain. It can lead to sedentary behavior and more loss of range of motion. So the more loss of pain, the more pain, the more loss of function, the more you get those pain cycles that Mercedes talked about. So we want to really avoid those pain cycles. And some of the natural history data that we participated in with the BBD is, pain begins at adolescence. Reports with more higher functioning patients, we have more reported pain, and it's a significant factor with adults. We've also seen that the energy expenditure index data from the 6-minute walk test is that there's an increased fatigue with patients with OI with age, but we can improve this fatigue with exercise. So patients reported improved fatigue with exercise. So you probably all heard this before, but we use what's called a biopsychosocial factor for treating pain at Kennedy Krieger. Your biology, your psychology, and your social environment are all important. And both Mercedes and Andrew also, talked about this, especially what Andrew spoke about in his presentation. As a physical therapist, I'm trying to impact your biology, but your genetics impact your pain, your neurochemistry. I can impact that a little bit as well as a physical therapist. The effects of medication, contribute to your biology. Biomechanics, that's also from me or the PT, and then age-related changes which happen with OI. But we also want to treat the psychology of your pain, right? We want to work on stress management. We do that as well at Kennedy Krieger, the anxiety, the mood, your thinking, your problem solving, your memory, and your beliefs. So these all impact your pain level. So, treatment for these also help manage and help you produce your pain. Oh, skipped again, sorry. We also look at some of your social factors, family factors that go on, the environment you live in, the social supports, your interpersonal style, as well your cultural beliefs and your socio-economic status. We try to address these also in the clinic to help reduce, because we find that these are significant factors that can help contribute to your pain. let's talk about some goals for pain and treatment OI from a physical therapist perspective. I want the course is to decrease your pain, but I also want to improve your function. Sometimes the improvement in function comes first before the pain decreases. So we really focus on trying to improve your function. We want to reduce your fatigue, build your endurance up. Fracture prevention is really important to treatment through treatment of weakness, right? It has a twofold benefit. It reduces your pain, but it also protects you against fracture. And it increased fracture may again lead you to deformity, and you get into some of those cycles that Mercedes talked about, where you're stuck fracturing and getting weak and resting, and fracturing, getting weak and resting. We want to avoid those painful cycles. So we do use a multidisciplinary approach at Kennedy Krieger. All disciplines working together across the aisle. I have sometimes even treat with a psychologist in my session. I'll be treating a patient with OI, and a psychologist there is helping them with their coping strategies while they're getting physical therapy. The psychologist and I will speak frequently about what coping strategies I can use during my PT sessions to help treat patients with OI who has having a lot of pain. And the goal would be, again, to start with function first and then move to pain reduction. But I also speak with the physician also about timing and medication, like when to take your medication so that you're prepared for PT and can participate in those activities before we go, on to the next level. So I talked about this before, how OA is present, it becomes worse. We do recommend some of the patients get joint replacements in the less severe forms of OI like type 1. And we've had a lot of success with patients getting joint replacements. So that was something I asked to talk about this thing. So don't be afraid to speak to your orthopedic doctor about joint replacement for type 1 OI. It's something that can be successful. We also want to address some of your leg length discrepancies. Those things happen frequently in patients with OI, and addressing those leg length discrepancies can improve some of your biomechanics and your body positioning. So we want to, and then because impaired leg length discrepancies can lead to imbalance and also contribute to your pain. So make sure. I get asked this question all the time about how do I treat a leg length difference, and I'd like to speak to the fact that we don't always address the actual difference. So if the orthopedic doctor measures you and says there's 4 inches that you're missing in your leg length, we don't address you with a 4-inch lift. We try to tune the lift to your comfort level and how you feel. So you'll come into the PT session and we'll adjust the lift to the level that you need and you feel comfortable with, and you can always come back and change it, rather than actually straight up addressing the difference that's reported by the doctor. So muscles, it's just an important thing to note that muscles are shock absorbers. They reduce stress on bone. Strengthening is really important to people with OI. It helps maintain joint alignment and joint stability as well. So muscle strengthening is an important aspect of treatment in PT. Again, reduces stress on tendons and muscles. Maintains alignment and freedom of movement. It prevents injury and improves muscle signaling. So people with OI typically who have contracture or misalignment, they have impaired proprioception and body awareness. So they can misstep or put their foot in the wrong position, which can lead to an injury. So we work on retraining the proprioceptive system in the body and make sure you know where you are in space so that we can prevent injury and also keep strengthening as well. Sometimes these signaling also leads to pain, so improving the signaling can reduce your pain level as well. We talked about strengthening already, how and I want to talk a little bit about how to strengthen with patients with OI. We really want to reduce the the lever arm on the arm and distribute the weight along the bone. So if you're strengthening somebody, with OI, you don't want to put the weight at the end of the limb and strengthen. You want to put it more proximal or along the long axis shaft of the bone when strengthening. So we're going to drive forces along the long axis and less force along the end of the bone to reduce. So proximal pressure as well as can reduce fracture. I get this question all the time about bridging, and I thought it was good to bring it up. We don't recommend typical bridging for an exercise with somebody with OI because it leads to torque on the tibias, but we do work on control, stability, and alignment is important for strengthening. So, and it helps with range of motion as well as again, reduces shock absorption and improves strength signaling to the muscles to reduce your pain. So I talked about reducing lever arms already, but be aware fatigue is an important factor with patients with OI. So your mitochondrial, is shown to be impaired. It's the powerhouse of the cell. You have less mitochondrial in your muscles, which can lead to fatigue. But exercise can increase the number of mitochondria as well as increase the powerhouse of the cell. So it's important to build your endurance up so that you're not fatigued to the point where you have pain because your pain leads. Weakness leads to fatigue. Fatigue leads to using less muscle. Using less muscle leads to bone-on-bone contact, which can increase your pain. So strengthening and endurance is important, but you will need to pace yourself. Typically people at OI need to do pacing along with endurance training to be able to strengthen themselves appropriately. And then I have the OIF guide for physical therapy here for as well for exercise, which is really important. It's a sectional exercise in that. So just muscle mobility and exercise in general loosens muscles. It reduces spasms. It improves blood flow. It helps with lubrication, so things move a little better. It impacts your brain chemistry. We know that exercise increases release of endorphins. It also increases dopamine. This helps improve your mental health as well as reduces some of your pain. I'm going to talk a little bit about some of the modalities we use in PT for pain treatment. Aquatics is really a nice exercise for patients with OI. And not only it reduces gravity and reduces stress on the joints, but also allows you to spread your weight distribution along the full axis of the bone and allows you to strengthen appropriately without reducing risk of fracture. I do use the modality of neuromuscular electrostimulation, and Mercedes talked about TENS. That's something we also use with patients with OI. We don't get a lot of success with TENS when it's placed directly on the muscle for the pain relief aspect, but when we combine TENS with things like stretching and exercise, we find it's more successful when it's combined. So applying that TENS unit to the muscle, if you have a spasm or a muscle that you are trying to make longer because your therapist is trying to make longer to help you improve your range of motion, we'll apply the TENS to that spasmed or tightened muscle during the stretching activity to help you relax a little better and reduce that stress on the muscle. Evidence has shown that this that TENS reduces the dystonia in patients with abnormal tone. So. And then the other thing I use the electrostimulation for is for strengthening as well as body positioning and muscle firing timing. So this is the TENS that's a little electrostimulation that's a little intenser and it goes directly on the muscle. So if you're learning to do a new movement or if you're immobilized for a period of time and can't activate your muscle, we'll incorporate some of the neuromuscular electrical stimulation to stimulate that muscle and get the blood flow to the area and be able to increase some of your strength before you can actually activate the muscle. Or if you're learning a timing activity and you don't quite have that step right, you can't get your knee all the way straight while you're swinging, I can combine the electrical stimulation on your muscle during that activity to help you improve your timing and learn some of your biomechanics and body awareness. I want to talk a little bit about intensive rehab. That's something else, another approach that we use at Kennedy Krieger for treatment of patients with pain. And we've had a couple successful patients recently with OI who went through some intensive rehab with us. Both adults and pediatrics. It's usually standard practice when outpatient's unsuccessful. So if you're going to PT once or twice a week and you're not getting relief from your pain and your function is getting worse, then we start to look at, maybe an interdisciplinary intensive rehab approach, is what you need. This is offered both in an outpatient setting at Kennedy Krieger and an inpatient setting as well. And it combines PT, OT, speech, psychology, and psychiatry in the same program to help you and you're getting therapy 2 to 3 hours a day with people helping you, supporting you to get through your pain. The goals are really to increase your mobility and function first with the pain. And then what we find is that as we increase your mobility and your function, your pain level and your coping strategies, the pain drops. They build pacing and endurance activities into these intensive rehab programs so that you learn how to pace yourself and improve your function, while you're having this pain. And we again show that this learning of pacing and building endurance first, along with pain, improves your function first, and then your pain level begins to drop. Again, some of the outcomes are to increase your function. We also work on improving the mental health, pacing to improve endurance, and the ultimate goal is to decrease the pain. These are my references. I want to thank you, the OI Foundation, for allowing me to participate today, and thank you.
All right. Hi, everyone. My name is Dr. Ricky Carroll. I'm part of the Nemours OI team. We're a multidisciplinary team. I trained in pediatrics and then did a fellowship in hospice and palliative medicine with a lot of pain and symptom management training and came to the OI team by way of that training. So on both the skeletal dysplasia and OI teams that I'm on, I do a lot of pain and symptom management. So today, to start, I do have a couple of disclosures, research funding, as well as consulting funding. And a lot of the photos are pictures of my patients who all families and kids gave me permission to use the photos today. Briefly, we'll talk about chronic pain. What is it? Although you've heard a ton of that already today. Why does it happen? Very briefly, and then we'll talk about how we treat it. Specifically, I'll talk about my approach, including medications. And then lastly, just one slide on infant pain, because it's something that's near and dear to my heart, but that is its whole other talk in and of itself. So hopefully in the future I can talk about that. All right, so chronic pain. What is chronic pain? The classic definition is pain that persists or reoccurs for longer than 3 months. And one of the other definitions that I think is more useful for today is long-standing pain that persists beyond the usual recovery period and or occurs alongside a chronic health condition. And what is chronic pain? So chronic pain can look like so many different things, right? We heard that today already. It can be bone pain, it can be joint pain, it can be joint stiffness, muscle spasms, muscle cramping, muscle fatigue, nerve pain, whole body fatigue, or it can be all these different things or a bunch of these different things. It can include multiple different systems, right? I see someone who has bone pain and joint stiffness, but also has migraines and also has abdominal cramping. So it has a lot of different system involvement. And those all add up to kind of whole body pain. And what is chronic pain in OI? Well, yeah, it is all those things, but it's also specific to OI. It's its own unique entity because it can be fracture pain that persists beyond your usual recovery pain. It could be post-operative pain that persists beyond what's expected. It could be frequent or recurrent bone pain, compression fractures or spinal curvature leading to back pain, it can be musculoskeletal pain, nerve pain, body fatigue, and so many other things, as we've heard about already a lot today. So why does it happen? You heard about this a bunch of times. There's this pain cycle. You have pain, and that leads to tensing up your muscles, which leads to pressure on the nerves, which leads to decreased circulation to that body area, which leads to inflammation and muscle shortening, which leads to restricted movement because it hurts to move it, which then affects sleep, which then affects, you have worry over how much worry over, is this pain going to last forever? When is it going to go away? When is it going to get better? Decreased movement leading to sadness and hopelessness, a lot of anxiety around it, which leads to more pain. So it's this hard, really challenging cycle that we're trying to break. And the other thing that I talk about a lot in my clinic with individuals with OI is the idea of chronic pain and sticky nerves. I kind of think about it similar to any other thing that we do, right? If you're learning how to knit, for example, so we have this lovely woman in the second row who's been knitting the whole time, right? And when she first started knitting, she was watching her every movement, learning how to knit, but she's gotten incredibly good at knitting. And now she's just looking around the room knitting, right? It's become kind of second nature to her. And that's because she practiced a lot. And that's the same with our nerves. Our nerves get really good. When you've had chronic pain and your nerves are signaling pain to our brain over and over again, they get really good at sending that pain signal to our brain. And it gets stuck in that pathway. And then suddenly things that didn't used to send pain signals are suddenly starting to send pain signals because your nerves have gotten really good at sending that pain signal over and over again. And so we need to tell them, the other thing is that pain is supposed to tell our body that we're in danger, right? It's supposed to say, like, your finger touches a stove, you feel pain, ouch, remove your hand from the stove. But sometimes our nerves get stuck in this pain signal pain signaling pathway, and we have to tell our nerves to relax. You're actually not in danger, and we need to retrain our nervous system and tell it to calm down. How do we do that? So the one thing that I, talk about a lot is the pain dial. So we have this dial of pain. Let's say you come in and your pain is a 10 out of 10. How are we? And you say, I'm functioning okay when my pain is a 5 out of 10. Right now, my pain's at a 10 out of 10. I can't function like this. How do we dial down the pain to a 5 out of 10? It's not by one thing. It's by multiple different things, right? We heard Mercedes and everyone talking about this today. It's not just doing one thing or taking one pill. It's doing this and doing that and doing this and doing that to dial down your pain dial to the level that you can function at. And so it kind of goes without saying, you need to know your body. You need to know your OI. You need to understand your OI, listen to your body. Of course, when needed, orthopedic evaluation, address your bone mineral density, thinking about pamidronate, that can be helpful, making sure your vitamin D is optimized, making sure that you're getting calcium in your day-to-day routine. But what else is there? So I'm going to talk about chronic pain related to OI, but like almost more generalized, what else can we do here? And the way that I approach chronic pain and OI is what I call the 3 M's: movement and mobility, which we heard a ton about, the mind-body connection, which we also heard a beautiful talk on, and medications. And I think you need to be doing all 3 things to bring down your pain dial. So movement and mobility, doing daily movement, gentle range of motion, moving your body every single day. If one part of your body is hurting, move the other parts of your body, because it is so common for me to hear. I had a lot of pain. I was in bed for a couple of days to let my fracture heal. And then when I tried to get up, I had pain everywhere. My whole body hurt, right? It's deconditioning. You're not moving your joints. You're not moving your muscles. You feel deconditioned. When you get out of bed after a couple of days, your whole body feels tired. And so it's making sure that even with the pain, you're getting up every day, you're moving your body, moving other parts of your body, doing whatever you can, even if it's just gentle range of motion of your neck or your shoulders or whatever it is, keeping other parts of your body moving. Aqua therapy can be incredibly helpful. If you're not bearing weight, trying to get into the pool can be really great. It is so common for me to hear that warm circulating water helps. So even if you just have a bathtub, you can buy something on Amazon that makes the water move, and using it as a true therapy. Like when you've had a hard day, get into warm circulating water and truly just let your joints and your muscles soak in that hot water can be incredibly therapeutic. Mobility devices, making sure that your mobility device fits you well, right? If you have a mobility device that's worsening your pain, then it's not doing what it's supposed to be doing. And please getting your mobility device checked and fitted to you on an annual basis. And think about having multiple different mobility devices that are specific to different activities, and using your body as much as you can when you can. So if it's going to be an activity where it's in a home, then maybe use your walker, whereas if it's in the community, then you're using your motorized chair or whatever else you have at access to you. The second M is the mind-body connection. We heard about this a lot. So there are multiple pain centers in your brain. One of the pain centers is called the amygdala, which is also the emotion center. So every single person's pain has an emotional component to it. And it is incredibly important that we, try to focus on the emotional component to pain in addition to other parts of the pain. And so we try to dial down the pain by dialing down the stress. Now, maybe it's bubbles, or maybe it's going to the beach, or maybe it's something else. So CBT, cognitive behavioral therapy, behavior psychology, or psychiatry, find a pain coach, find a therapist who knows how to work with people who have chronic pain and can talk through what it's like to live with chronic pain in a safe, unbiased environment, and help talk through different coping mechanisms that are specific to you. And then if you're if you get home, it's been a really hard day, your body is hurting, maybe you have a medication that you take that medication, but it takes 30 to 45 minutes to kick in. You're gonna turn on the bath, you're gonna start, your hot steamy bath, and you're gonna put on one of these apps that's a guided imagery or a meditation or a deep breathing exercise. And that's how we dial down the pain, right? You get in the hot bath and that dials down your pain from a 10 to a 9, and you take your medicine and it dials it down from a 9 to a 7, and you do guided imagery and it dials it down from a 7 to a 6. And so it's just doing multiple things all at once to bring the pain down as best we can. Oh, I just screwed it up. I'm so sorry. Oh, here we go. Thank you. I'm going the wrong way now. Okay, so the third M is medications. And I'm going to talk about different medications that I talk to individuals about who have chronic pain in OI. So the one that we've heard about today that gets a lot of bang for its buck is NSAIDs, or non-steroidal anti-inflammatory drugs. The most common one that you've heard of is ibuprofen or Motrin or Advil. But there are other ones, of course. Naproxen is known as Aleve. The beautiful part about Aleve is that it's every 12-hour dosing. So if you find that you're taking Motrin on a regular basis, sometimes rotating to Aleve that you only have to take twice a day as opposed to Motrin that you're taking 3 or 4 times a day can be really helpful. The other thing is that sometimes people find that one NSAID works better than another for them. So even if ibuprofen or Motrin hasn't been working, trying Aleve or Mobic or Celebrex could get you better bang for your buck. Being careful, NSAIDs can hurt your belly, so making sure that you take it with food. If you have a history of ulcers or bleeding, this isn't the drug for you. As well as if you have any kidney disease or diabetes, likely your nephrologist will tell you to stay away from NSAIDs. And you can't mix NSAIDs because we don't want to overdose on NSAIDs. So if you are someone who takes Motrin, but you want to try Aleve, you can't take Aleve and then take Motrin for your breakthrough pain. That's double dipping into the NSAID bucket. So for some of my patients who are taking ibuprofen all the time, or they're taking Aleve all the time, and they're taking Tylenol all the time, and they are just not getting relief, I'll talk about gabapentinoids. Gabapentinoids are an umbrella of medicines that are really good for nerve pain. And you might say, like, I don't have nerve pain, I have bone pain. Your bones are covered in nerves, right? And your joints are covered in nerves too. So a lot of people who have chronic pain have a neuropathic component to it. So I typically will reach for a gabapentinoid as a first-line agent if your over-the-counter medicines aren't working. One thing to say is that I feel like physicians or providers get really antsy about the dosing in people with OI and dysplasias because of differences in body proportions and size. And so it's really common for me to see a patient who's on like a whiff of a dose and saying it's not helping. So you really need to make sure that you're actually getting a full dose of gabapentin to see if it helps or not. The trade name for gabapentin is Neurontin. And typically I'll titrate up to the dose that's needed up to around 900 milligrams 3 times a day. So it's really common for me to have someone come in and say, oh, I'm on 100 milligrams at night, it doesn't help. And I'm like, that is a tiny dose. And then if gabapentin isn't working or there's side effects that someone doesn't like, I'll sometimes rotate to pregabalin or Lyrica, and sometimes find that has a better side effect profile for some people. These medicines can cause some drowsiness, so I typically start with a tiny nighttime dose to get the body acquainted and then slowly titrate up over time. So I don't go right to 900 3 times a day. I'll start at like 100 at night and then slowly titrate up, working with the patient and the family really closely. Another medicine that I use really commonly are the SNRIs. So SNRIs are a group of medicines that were originally FDA approved for anxiety and depression. And then people who who were started on them, who also had chronic pain, were like, wait a minute, my chronic pain got better. And so the company who made the SNRIs went back and did studies, and it's now FDA approved for chronic neuropathic pain. So if I have a individual in front of me who has chronic pain and also has a lot of worry or sadness around their pain, I typically will reach for my Cymbalta and start that and find it really successful. Again, I titrate over a number of weeks. I start low, I go slow, and I go to the lowest dose that we need to get the effect that we're looking for. The thing to know about SNRIs is that it takes a long time to work. You really need to give it 6 to 8 weeks to see full effect. So it's common for a family to message me a weekend and be like, there's no difference. And I'm like, yeah, well, we got to give it more time. So you just need to be patient with this one. It can cause drowsiness. I typically start it at night. Usually that goes away within a week, but it's just like getting the body used to it. You can have some belly upset. I haven't seen that much actually, but it is on the warning label. And it does have this theoretic increased risk of bleeding. So if you're taking Aleve or Motrin all the time and taking Cymbalta, that can kind of double your risk of having easy bleeding and bruising. So it's just something that I watch closely if I start someone on it. Another medicine that I sometimes think about is the group of tricyclic antidepressants. These medicines, again, were originally FDA approved for antidepressant as an antidepressant, and they were found to be for depression, and then people realized that they were really good for chronic pain. These medicines also are good, like our sleep agents. Like they cause drowsiness and that continues long term. So for individuals who have chronic pain and have a lot of trouble sleeping because of their pain, I'll think about using amitriptyline or Elavil as a first line agent for that. Again, titrating over a number of weeks. It does have a lot of anticholinergic properties, which just means it can cause constipation. It can cause urinary retention at high doses. So I usually start quite low and titrate up slowly. And if someone has a history of constipation, which is another big issue within the OI community, I could talk about poop all day, but I won't. If there is constipation, then I'll usually start like a bowel regimen with this medicine. And then lastly, in adults, it has been shown to precipitate arrhythmia in those with pre-existing heart conditions. So I typically do get an EKG prior to starting. And if there is a history of cardiac concerns, then this usually wouldn't be the medicine that I would reach for. Alpha agonists. So I love clonidine. I think it's a really good medicine. It's an alpha agonist, which means it's actually a blood pressure medicine. And then was found to be really good for chronic pain as well. And it's also really nice for anxiety. For those that have high blood pressure and high heart rate related to their pain, clonidine can be a really nice agent. It can, again, cause some sleepiness. So for those that are having trouble sleeping because of their pain, I would start a small dose at night. And for adults who have chronic pain and hypertension, it's a really nice double agent for that. It does come in a patch, which is also a nice option. I also love topicals. I typically, in addition to oral medicines, will recommend using topicals. There's a lot of different options out there. Not pediatrics, but in my young adults and adults, icy hot seems to be something that a lot of people love. Yeah. It actually has like aspirin-like properties in it, and people find it really helpful. Voltaren is like ibuprofen in gel form. So if you have a specific joint that's really uncomfortable, rubbing Motrin on that joint can be very helpful. And some people love capsaicin. It's, the active component in chili peppers. It gives you this like spark of hot, icy hot effect, and people like that as well. I definitely have some patients come to me and say, I really want natural remedies. And these are two that I usually go for. One is curcumin, or the active component in turmeric, and the other is resveratrol, which is the active component in red wine. They both have, with turmeric, it has anti-inflammatory properties, pain relief comparable to ibuprofen. And in resveratrol, it has antioxidant and anti-inflammatory component to it. It also can be an antihypertensive and an antiplatelet aggregate. So if someone is already on blood pressure medicines, I wouldn't recommend that medicine. And if someone is already on a blood thinner, I wouldn't recommend that. But there are some studies in other skeletal dysplasias which have shown these herbal remedies to be effective. I would love to do a study in the OI population to see if that can extrapolate to us. But in the meantime, I have tried it in some with OI and have had some good results. Briefly on medical marijuana, I know some people find it incredibly helpful. I'm not opposed at all. I think just it's important to know what you're getting into when you use medical marijuana. There are some limited data to show that it can help with pain and help with sleep, but it can also worsen anxiety for some. So just being careful. Try to limit the THC as much as possible. That's the hallucinogenic component to medical marijuana. Of course, there's no insurance coverage for medical marijuana, so it's quite expensive. Start super low, go very slow. Briefly on opioids. So opioids are a beautiful medicine. They do an incredible job with acute pain. They are great for fracture-related care or post-operative pain, but they are not good for long-term chronic pain. For every single person, they cause tolerance and dependence. So when you are on an opioid for more than 7 days, your body becomes dependent on opioids for affecting the opioid receptors in your body. And if you stop it cold turkey, you will have withdrawal. That's for every person. And everyone has tolerance. So if you're on it for more than a week or two, over time, you need a higher dose to feel the same effect that you originally had. And so for that reason, they have high addictive potential and are not good for chronic pain. They also have a lot of side effects related to them, and have been shown to cause opioid-related osteoporosis. So really not great for our OI community. And actually can cause increased pain over time. They can cause hyperalgesia, so they can really cause your nerves to be super sensitive to pain signals. And then just briefly, caring for an infant with OI. This is near and dear to my heart, and something that I could give a talk on for a good hour. But all that to say, there's a paper out there that we wrote on pain management for infants with OI. The Navigating the New Diagnosis Toolkit by the OIF is a beautiful resource for families who are facing a new diagnosis of OI. And pain management is a key component to the early stage of OI management. And I'm happy to help any family or any physician who has any questions about that. Thank you so much.
Wow, that was amazing. Right? How great was that? Wasn't that fantastic? Oh my gosh. Thank you all so much. Thank you for that amazing presentation. Thank you for your interest in helping to alleviate the pain with the OI community. We can't thank you enough. We are going to take some questions. We are short on time. So we have, right, Melissa? Do we have a few minutes? Oh, we don't? We're done? I thought we had till 11. Oh my gosh. We are done. So pretend I didn't say that, rewind, but they're here. The team is here. Yes, so the team is here. Come find them. They're hanging around. They'll stay for a few minutes, right? At least here today, but find them in the hallways And if you don't get your question answered, because I'm sure a lot of you have specific questions, you can email the foundation, and it is bonelink@oif.org. Does everyone have that email? Bonelink@oif.org. So if you can't track the team down up here and you have additional questions, please email them. We will get you answers. That I can guarantee you. So thanks to everyone for coming. Thank you to our amazing team again. We really appreciate you. All right, go enjoy your last day. See you at the dinner.